Hello dear students, today we are going to have our flip class 3 and the topic is renal diseases, under which I am going to talk about nephrotic syndrome. Nephrotic syndrome by definition has certain laboratory and clinical criteria and which are laid out as massive proteinuria, hypoalbuminemia, evidence of fluid retention or edema, and when it is generalized it's called as anasarca and usually associated with a high cholesterol level. Now coming to the pathophysiology of nephrotic syndrome, patients will have a urinary protein loss of more than 3.5 grams of albumin per day, and that is the main cause of hypoalbuminemia. And in fact the mechanism of this kind of a massive proteinuria, where albumin is the main protein, is complex. It occurs partly because of structural damage to glomerular basement membrane, leading to an increase in the size and number of pores which are going to be seen electronic microscope wise, and they are allowing the passage of more and more larger molecules. Otherwise these molecules will never escape the glomerular basement membrane because it's tight. There is a change in the electrical polarity in glomerular capillary wall. There is a fixed negative charged components present in the glomerular capillary walls, and they will repel the negatively charged protein molecules. And this is one of the main mechanisms. And I would like to show a pictorial depiction for you all. So just look at this picture where there is a normal glomerular capillary, and that's in comparison with the capillary where there is a cascade of proteinuria which is unstoppable. And look at the red cells also within the glomerular basement membrane. And now we have a depiction of our glomerular basement membrane plus the epithelial cells which are there in the and they're called as the main pathogenesis for the minimal change disease, which is one of the nephrotic syndromes common in children. I'm going to explain further. And you could see in the electron microscope there is a loss of the foot processes too. Now let's come to the causes. We have main division of non-inflammatory glomerulonephritis and we have proliferative or inflammatory glomerulonephritis. Let's list the very common ones. The most common is minimal change disease. It's also called as minimal change nephropathy, and here it's a real common condition for children, and even in adults, like as many as if 80% of children get, and even 20% of adults can suffer from this. And the next one is focal segmental glomerulosclerosis, and the last one membranous nephropathy. This is more common in adult patients. Let's move on to the inflammatory glomerulonephritis. Here we have mesangiocapillary glomerulonephritis, and less common ones called as subacute proliferative and SLE. SLE has some 5 different histologies in the lupus nephritis, which we can discuss later. And as we go on, coming to the systemic diseases which involve the kidney. Here primarily the kidney is not involved. They are mainly for our concern, it's diabetes mellitus type 2, and then we have amyloidosis, we have SLE again there, and drugs like penicillamine, captopril, heavy metals, especially gold, cadmium, mercury. Nowadays it's less commonly used, these heavy metals. And allergic reactions to poisons, especially IV poison, pollen grains, bee stings and cow's milk allergy. Now we come to the renal disorders not associated with nephrotic syndrome. These are important to know because their clinical manifestation would come to you in the same spectrum where you call them as differential diagnosis. These are reflux nephropathy, chronic tubulointerstitial nephritis, renal tuberculosis and polycystic disease. Now let me come to the causes again. In a nutshell, we divide them as primary glomerular diseases. They are minimal change disease, membranous glomerulonephritis, FSGS, membranoproliferative called as MPGN, and mesangioproliferative glomerulonephritis. The secondary ones, I am elaborating the list: infections like infective endocarditis, hepatitis B, quartan malaria, sepsis, neoplasms like carcinomas of the solid organs, lymphomas, leukemias and multiple myeloma. And multisystem disorders, like the key things you should remember are diabetes mellitus and systemic lupus erythematosus, and uncommonly rheumatoid arthritis, amyloidosis primary and Henoch-Schönlein purpura. Let's come to the pathophysiology in a nutshell. Here you see there is a primary glomerular injury. The intact glomeruli are injured, and then there will be a cascade of reactions. This will lead to increased glomerular permeability, and which leads to proteinuria, which can go up to massive proteinuria, and we have a resultant reduction in the plasma oncotic pressure, and which is an immediate cause for the peripheral edema. And the decreased plasma volume hence leads to a decreased cardiac output, and this will start off a chain of neurohumoral responses. In that I have just summarized the increased sympathetic activity, increased catecholamine levels in the blood, and RAA stimulation, renin, angiotensin, aldosterone axis stimulation, and all these together lead to renal, water and sodium retention. Let's come to the clinical features. We always get a clue in the history, and we do look for family history of atopy or renal disease, and we also have to look for a classical history of passing frothy urine, which always suggests a massive proteinuria. Now, clinical examination wise, patients will have anasarca or generalized edema, ascites particularly in children, and in male children the scrotal edema, and in girls you should look for the labial edema. Facial puffiness will be classical, early morning facial puffiness and periorbital swelling, and always look for the underlying disorder which has produced nephrotic syndrome and their classical features. Example, malar rash in SLE, neuropathy, retinopathy and other telltale evidence of diabetic target organ damage. JVP will always be normal in nephrotic syndrome unless there is a cardiac cause or associated cardiac failure which has contributed for the edema. This is the picture of a child with nephrotic syndrome where you are seeing the periorbital swelling and the facial puffiness.